just have to listen it to 2x speed for 2 to 3 times at once every week, and you'll memorize it in no time. So routine ultrasound in pregnancy types: transabdominal, transvaginal. Transvaginal, all structures seen 1 week earlier than transabdominal. Frequency of probe: transvaginal is 5 to 10 Hz, transabdominal is 3 to 10 Hz. Mode: B mode, brightness mode, visualize all intrauterine structures. M mode, motion mode, to see cardiac activity. Ultrasound finding in pregnancy: gestational sac. First structure seen on ultrasound: appearance symmetrical fluid filled area with echogenic rim. Seen at transvaginal ultrasound 4 weeks, that is 1 month plus 3 days, to 5 weeks. So at 1 month you can see this. Indicates pregnancy. And no, gestational sac does not indicate intrauterine pregnancy. In ectopic pregnancy, pseudogestational sac is seen. Yolk sac, second structure seen on ultrasound. Appearance bubble inside gestational sac. Appears when mean sac diameter is 10 mm. Seen at transvaginal sonography at 5 weeks to 5 weeks plus 3 days. Indicates intrauterine pregnancy. So yolk sac indicates intrauterine pregnancy. Note: if gestational sac is more than 10 mm and no yolk sac visible, suspect ectopic pregnancy. In ectopic pregnancy, gestational sac with yolk sac in fetal tube. Thick decidua, pseudogestational sac due to progesterone. Fetal pole: crown rump length can be measured. Seen at transvaginal ultrasound 5 weeks plus 3 days to 6 weeks. Cardiac activity on motion mode: seen at transvaginal ultrasound 6 weeks to 6 weeks plus 3 days. Crown rump length is 1 to 5 mm, and MSD is 13 to 18 mm. Fetal heart rate at 6 weeks is 110 to 130 beats per minute. At 8 weeks is 160 to 170 beats per minute. If less than 85 beats per minute, bad prognosis. Missed abortion. Gestational sac, mean sac diameter, cutoff value to measure CRL, visualize fetal pole 25 mm. MSD less than 25 mm plus no fetal pole, repeat ultrasound in 1 week. More than equal to 25 mm plus no fetal pole, crown rump length cannot be measured. Missed abortion, fetal structure cannot be identified, known as blighted ovum and embryonic pregnancy loss, medical abortion. Crown rump length, cutoff value to visualize cardiac activity is 7 mm. Crown rump length less than 7 mm plus cardiac activity absent, repeat ultrasound in 1 week. More than equal to 7 mm plus cardiac activity absent, missed abortion, medical abortion. Diagnosis of missed abortion on ultrasound. Specific criteria: if MST is more than 25 mm. That is mean sac diameter. MST is mean sac diameter is more than 25 mm plus fetal pole not seen. Crown rump length cannot be measured. That is missed abortion. If crown rump length is more than 7 mm but no cardiac activity present, that is missed abortion. If more than 14 days have passed after scan showing gestational sac, yolk sac, cardiac activity absent, that is missed abortion. If more than 11 days passed after scan showing gestational sac plus yolk sac but cardiac activity absent, that is missed abortion. Beta HCG, cutoff value to visualize gestation, critical titer. For transvaginal sonography, 2000 intrauterine per liter. For transabdominal sonography, 6500 intrauterine per liter. Here, when a patient tests positive pregnancy on the urine dipstick, then this is the first test that is done to confirm the pregnancy. If value is more than 2000 intrauterine per liter on ultrasound and gestational sac is not seen, then ectopic pregnancy. Minimum HCG value at which gestational sac is visible is transvaginal ultrasound is 1000 intrauterine per liter. Beta HCG repeat value after 24 hours doubled. Live intrauterine pregnancy increased but not double. Ectopic pregnancy decrease. Dying intrauterine pregnancy abortion. Note: location. The gestational sac and pseudo-gestational sac. What is the difference? Location: true is eccentric, pseudo is central. Growth 2 to 3 mm per day. No growth. Then double decidual sac sign, yolk sac, double blab sign, yolk sac plus amniotic sac is all present in the true gestational sac but absent in the pseudo-gestational sac. Early pregnancy on ultrasound. Signs: intradecidual sign. First sign: gestational sac first rupture, indicates interstitial implantation or blastocyst. Double decidual sac, double ring sign. Second ring, inner ring decidua capsularis, outer ring decidua parietalis, indicates intrauterine pregnancy. Decidua capsularis, decidua parietalis. Double blab sign. Third sign: one blab, yolk sac. Second blab, amniotic sac, indicates intrauterine pregnancy. Estimation of gestational age. Earlier the ultrasound, more the accuracy of gestational age of fetus. First trimester is best time. Crown rump length is best parameter. Second trimester biparietal diameter. Third trimester combinations of parameters, single best is femur length. Mean sac diameter. Mean sac diameter can be measured before crown rump length for estimation of gestational age. Mean sac diameter in millimeters plus 30 is equal to gestational age in days. In my other videos, I will show you true patient examples and their ultrasound findings and how we calculate the gestational age in such cases. Crown. So please subscribe to my channel and keep checking out for all the videos to not miss anything. Crown rump length used till 13 weeks plus 6 days and crown rump length less than 84 mm. If crown rump length is more than 84 mm, then use biparietal diameter. Crown rump length in millimeter plus 42 is equal to gestational age in days. Smallest crown rump length measured on ultrasound is 5 mm. Most accurate estimation between 7 to 9 weeks. If in twin pregnancy, if discrepancy is present, estimated delivery date is calculated based on larger twin. Biparietal diameter measured in transthalamic plane, thalamus and third ventricle visible, measured from outer table on one side to inner table on opposite side, outer table, inner table, third ventricle, thalamus. Abdominal circumference for fetal growth. Indications and recommendations of ultrasound. Indication of ultrasound in first trimester. Patient is unsure about last menstrual period. Size of uterus does not correspond to period of gestation. Complain of pain in abdomen to rule out ectopic pregnancy. Complain of bleeding in first trimester to know viability. Ultrasound recommendations in pregnancy. Viability scan is seen in 6 to 8 weeks. Knuckle translucency scan 11 to 13 13 weeks plus 6 days. Target anomaly block booking scan 18 to 22 weeks, also known as TIFA. Targeting imaging for fetal anomalies level 2 scan should be done in all pregnant women. Knuckle translucency scan 11 to 13 weeks plus 6 days. Growth scan 32 to 34 weeks. Ultrasound of uses of ultrasound. Measurement of cervical length in preterm labor. In all pregnant females with history of preterm labor, a transvaginal ultrasound should be done between 16 to 24 weeks to measure cervical length. Method: bladder should be empty if internal os is closed. Measure distance between the internal os and external os. If there is a protrusion of amniotic membrane in endocervix, tip of funnel should be taken as internal os. Placental localization 32 weeks best time, repeats 36 weeks. Chorionicity in twins 10 to 14 weeks. Short femur indicates constitutional delay, Down syndrome. Severely short femur indicates skeletal dysplasia, early onset intrauterine growth retardation. Suboptimally dated pregnancy. No ultrasound was done at less than 22 weeks. Single ultrasound is not helpful. Serial ultrasound 3 to 4 weeks. Estimate gestational age to rule out IUGR. Fetal echo not routinely done. Done between 22 to 24 weeks. Indication suspecting fetal cardiac disease. Fetal heart rate shows arrhythmia, rubella infection of mother, increased risk of patent ductus arteriosus, fetal aneuploidy, Down syndrome, endocardial cushion if defect, knuckle tube trans NT is more than equal to 3 mm, monochorionic twin TTTS syndrome, chances of heart failure in recipient twin, lithium therapy abstinence anomaly, history of fetus with heart block in setting of maternal anti-ROLA antibodies SLE, gestational diabetes, increased risk of VSD, phenylketonuria, risk of microcephaly and CVS abnormality. Ultrasound in pregnancy too. Investigation of choice for congenital malformations. Ultrasound TIFA level 2 scan, routine ultrasound level 1 scan. TIFA level 2 scan is best between 18 to 22 weeks. Gross congenital anomalies, TIFA, structural defect, chromosomal anomalies, karyotyping. Routine ultrasound level 1 can detect some congenital malformations as neural tube defects. Neural tube defects, any defect in closure of neuropore or fusion of neural tube. Cranial defect, cranial neuropole fails to close, acrania. Absence of skull, meninges and muscles. Brain tissue herniates out, lies in contact with amniotic fluid. Destruction and degeneration of brain tissue, anencephaly. Encephalocele. Encephalocele on ultrasound. Small defect, meninges and brain tissues herniate out, covered with meninges and scalp. Encephalocele. Most common site, occipital lobe. Anencephaly, salient features, acrania, adrenal and pituitary glands are absent or hypoplastic, increased risk of postpartum pregnancy, decreased fetal DHEAs, decreased estrogen level, decreased uterine contraction, associated swallowing defect, polyhydramnios, uterine overdistension, preterm labor, postpartum pregnancy with preterm labor. Postpartum pregnancy is more common than preterm labor. Most common presentation face of fetus is normal. Non-viable condition, anencephaly. On ultrasound, first congenital anomaly to be recognized on ultrasound. Earliest detection on ultrasound 10 weeks, trimester 1. Best time to detect is 2 weeks, and we are talking about anencephaly. Deep sockets, frog eye sign. Deep sockets, frog eye sign. Signs on ultrasound. Shower cap sign, irregular contour of head on fetus. Mickey Mouse sound, triangular face. Frog eye sign, big bulging eye, deep socket. In trimester 3 or late trimester 2, polyhydramnios. Management, medical termination of pregnancy, irrespective of gestational age, after being decided by medical board. Ultrasound anencephaly. Recurrent risk of neural tube defects after 1 5%, after 2 10%. Prevention of neural tube defects, folic acid supplementation, dose 500 microgram per day, dose to prevent recurrence, therapeutic dose 4 milligram per day. Note, hyperthermia fever in first trimester, temperature increases by 1.5% Celsius, teratogenic, neural tube defect, microcephaly, learning disability, seizures. The diagnosis of neural tube defect, screening test, current level 1 ultrasound, maternal serum, AFP levels. Diagnostic test, level 2 ultrasound, TIFA scan, amniocentesis. Earlier was amniocentesis, AFP, and acetylcholine esterase levels. But now level 2 ultrasound, TIFA currently. Screening test level 1, diagnostic level 2. Best biochemical marker of neural tube defect is acetylcholine esterase. Best biochemical marker, not used anymore. Now level 2 scan is used. Caudal defect of neural tube. Prevalence 1 in 2000 births. Caudal defect, spina bifida, non-closure of vertebral arches, no herniation of meninges, plus no herniation of spinal cord. Spina bifida occulta, tuft of hair, skin, meninges, spinal cord. No herniation of meninges, no herniation of spinal cord, meningocele. Herniation of meninges, herniation of spinal cord, meningomyocele. Spina bifida aperta, spina bifida occulta. On ultrasound, banana sign, downward displacement of cerebellum. Lemon sign, bossing of frontal lobe. Associated ventriculomegaly. Polyhydramnios. These signs are also seen in Arnold Chiari 2 malformation. Meningomyocele. Banana sign, downward displacement of cerebellum. Lemon sign, frontal bossing. Cranioarchesis, cranial plus caudal neural tube defect both. Anencephaly, spinal bifida. Note, cephalocele, herniation of meninges through cranial defect. Anencephalocele, herniation of brain and meninges through cranial defect. Chiari 3 malformation. Anencephalocele plus herniation of cerebellum and other posterior fossa structures. Cranioarchesis. Abdominal wall defect, omphalocele versus gastroschisis. Defect, omphalocele, herniation of abdominal contents enclosed in a sac. Gastroschisis, herniation of abdominal contents not enclosed in a sac. Omphalocele, smooth outline from umbilicus. Trisomy 18 more than trisomy 20. Karyotyping required. Gastroschisis, cauliflower-like appearance. Left and right of umbilicus not required. Note, physiological herniation of abdominal content through umbilical till 9 to 11 weeks of pregnancy. Diagnosis of omphalocele should always be after 11 weeks. Alpha fetoprotein. Salient features: fetal specific globulin synthesized by fetal yolk sac plus fetal GIT and liver. Maximum level in fetal serum at 13 weeks of pregnancy. If alpha fetoprotein increased, produced by fetus, AFP in amniotic fluid. Maternal serum alpha fetoprotein, ideally between 16 to 18 weeks, earliest by 15 weeks. In first trimester, sensitivity is very low. Fetal conditions associated with raised AFP levels: neural tube defect, abdominal wall defect, pilonodal sinus, fetal death. Decreased AFP levels: mnemonic, diabetic goat. Decreased AFP levels is seen in maternal diabetes, gestational trophoblastic disease, overestimated gestational age, abortion, trisomy of fetus. So in our next topic